Hey, it's 1 o'clock, so we're going to get started. Welcome, everybody. We're really excited to have everyone here on this, my area in Philadelphia, sunny afternoon in January. So today's method session, SAVIR method session, is Unlocking Insights with Fatality Review and Data. And it's sponsored by the National Center for Fatality Review and Prevention. Our moderator today is Sasha Mintz, their senior epidemiologist. We're really excited to have all of you. This is a classroom format. We would love interaction with our speakers, with each other. So if you can pop into the chat, your name, where you're joining us today from, what you're hoping to get out of this maybe, or something else. We'll keep an eye on the chat.
Hiding from the Nazis in
Oh,
Chamber
we're gonna
9.
ask everyone to mute themselves just for right now. So we'll keep an eye on the chat. The session is recorded and accessible afterwards, along with any of the materials. I'll be popping information into the chat box, such as speaker bios, and all the presenters will go, and then there'll be a moderated question and answer at the end. I'll be keeping an eye on the chat for questions. Feel free to pop them in there or wait until the end during the question and answer, but we'll keep an eye on them so they don't get lost. And without further ado, I'm going to hand it over to Sasha. Thank you all for joining us.
Thank you, Kristen, and thanks everyone for being here. I'm just going to share my slides. Let me know if you don't see them, but I think you do. First, I know that not everyone has heard of child death review before. So before we hear about the specific research that uses child death review data, what I want to do is provide a brief overview of what child death review is and how the data are collected. As Kristen said, my name is Sasha Mintz. I'm a senior epidemiologist with the National Center for Fatality Review and Prevention, and I have no financial relationships or interests to disclose. And I would like to acknowledge our key funding partner at the National Center, which is the Health Resources and Services Administration's Maternal and Child Health Bureau. We are very grateful for their partnership and their support, but the contents of this presentation are solely my responsibility and should not be construed as the official position or policy of the federal government. I'm going to provide a background about the child death review process, how data are collected, how data are then used for research, and then finally introduce some of our amazing folks who have experience with using our data for research. Starting with that brief overview, child death review is the multidisciplinary review of individual child deaths to help communities understand why children die. The process really illuminates both the strengths and the opportunities for improvement in the systems that families interact with, highlighting disparities in how families access and navigate systems. One of the core tenets of child death review is that it is prevention focused, really equipping communities to effectively prevent future deaths. Now, the child death review process can look different from program to program across the country, but it often follows this same general flow. First is case selection. So often, depending on the legislation in each state, the program selects deaths that will receive a review. In some states, it's all child deaths among children under the age of 18. In some states, it's only deaths due to injury and violence. So it varies. Once deaths are selected for review, multidisciplinary team members are convened for a review meeting in which they all bring the records and information that they have about the child's family, and their community. Team members come from a variety of professional areas, which often includes coroners and medical examiners, law enforcement, human services, public health, schools, medicine. It really runs the whole range of professional folks that come into contact with families. Now, based on this available information, a review is conducted in which the team discusses the circumstances of the death, and data are entered into a standardized system that I'll talk a lot more about here in a moment. And then the team generates recommendations for prevention. And then hopefully the team catalyzes action by taking those recommendations and creating prevention strategies at all levels, at the local, state, and territorial, and national levels. So just as a summary, child death review programs often review the deaths of children from birth through their 18th birthday, and the goal of the team is never to place blame for the death, but rather to seek to understand how systems can be improved to prevent future deaths. Currently, there are child death review programs in all 50 states, the District of Columbia, Guam, Puerto Rico, and the US Virgin Islands, totaling to more than 1,350 teams. Now, where does the National Center come into the process? Well, the National Center, which is the organization where I work, we are the technical support and data center serving all child death review programs through training, through resources, and data support. Our goal is to really support
That's
all
great. Happy to see
1,350
you.
teams, however we can, whether it be through on-site assistance during a review meeting, help with strategic planning, or assistance with collecting and entering their data, which take me to my next section. How are data collected through child death review? Well, in 2005, the National Center developed the Pediatric National Fatality Review Case Reporting System, and we continue to maintain the system and make improvements. It's a free web-based data system available to every child death review team as a way to collect data in a standardized way. The goal of the case reporting system is to collect a very wide variety of information about the child, their family, and the context in their community. And just like the child death review process itself, the case reporting system is focused on how systems function and documents everything from individual characteristics of the child and their family, circumstances of the death, risk and protective factors, to those prevention strategies that are generated by the review team. The case reporting system is driven by cause of death, which guides the questions that are available for a data entry user in the system. The case reporting system contains more than 2,500 variables, which sounds like so many, but there are skip patterns that make the data entry more efficient. And what this means is kind of displayed here on the screen, where the first several sections of the case reporting system outlined there at the top of the slide will guide the user through collecting and entering information about the child, their biological parents, their primary caregivers, and their supervisor at the time of the incident. They'll collect and enter information about the incident leading to the death, about the death investigation itself, and then finally about the official manner and primary cause of death. Now, depending on how the user completes manner and cause of death, additional sections will then open to complete more questions. So there's a few examples here on the slide, but as just one example, if the user indicates that the child died in a car crash, that section H1 will become available to complete questions specific to motor vehicle and other transportation events. So we'll be able to collect information about types of vehicles involved in the incident, whether the child was the driver of a vehicle, a passenger, maybe they were riding a bicycle or they were a pedestrian. So we're able to collect those more circumstantial pieces of information. And just to say, we have cause of death specific sections for all types of child deaths that are being reviewed and entered into the system, including poisoning, suicide, medical conditions, drowning, and so on. Right now, there are 48 states using the case reporting system for child death review. And the states currently not using it are actively working towards being able to do so. Like any data system, there are limitations. I'm going to go over a few of the general limitations of the case reporting system, and then our presenters here in a bit will share some specific limitations to their projects that they conducted. The first limitation, as I mentioned before, is that the child death review process can vary from program to program, and not all programs use the case reporting system. The next limitation is that the case reporting system only includes deaths that are undergoing a review or had a review. So it's not a census of all child deaths occurring in the United States. So the aggregated national data from the case reporting system cannot be compared to vital statistics data. It can't be used to calculate rates or trends, and it can't be assumed to be a representative sample. And then finally, data quality is a limitation. As I shared, there are 48 states using the data system, which comes to about 2,300 different people entering data representing those 1,350 child death review teams, which now culminates to more than 300,000 unique records for deaths that are entered into the case reporting system. So as you can imagine, with so many data elements in the case reporting system and so many people involved, consistency within and across jurisdictions and the completeness of the data can be quite a challenge. And we're working to improve it all the time. But that's not to say that there aren't very unique strengths. The case reporting system is such an important data source for research and prevention. Fatality review data provide a depth of valuable information that is not available from any other single data source. There's, again, a few examples listed on the slide, but to state just one, we're able to understand the complexities of infant sleep-related deaths, including information about the infant, about their caregivers, about the infant's sleep surface, how their airway was found, what other objects were in the sleep environment. So all of these circumstantial pieces we're able to find from child death review data. And that brings me to my final section. How can these data be used for research? Well, the National Center has developed policies and guidelines for researchers that are interested in using de-identified data from the case reporting system. Right now, there are 231,000 deaths in a researcher data set, which are available for use through an application process. Once an application for the data are received, we have a committee of experts who assess the research questions, proposed methodology, and the consistency, again, with our core mission of prevention. You can find these policies, a blank application, and even a sample application on the data dissemination page of our website. These are just a sample of recent papers that used case reporting system data through our data dissemination application process. You can see that they span a wide variety of topics like firearm deaths, child maltreatment, poisonings, vehicular heat stroke, infant deaths, and suicide. I'll drop a link here in the chat in a bit to a comprehensive list of publications using the case reporting system data. We're also really proud to share a recent supplement of pediatrics that was published in November, highlighting more insights from Fatality Review. The 17 articles in this supplement also cover a wide range of topics, really showing how versatile these data can be. I'll leave this slide up for a moment to give folks time to scan, but there will also be links dropped in the chat for you, and you'll have access to these slides again later. That first code is for the video abstract to the supplement, which also includes a really great introduction to child death review and fetal and infant mortality review, so I encourage you to check that out. And the second code is straight to those supplement articles, which are open access and available for you to explore right now. You can always reach us at the National Center at our email address, which is info@ncfrp.org. And you can also explore our website at www.ncfrp.org. And now for the stars of the show, our incredible researchers who have used data from the case reporting system and will share more about their individual projects. First, we'll have Dr. Chris Gaw, who is an assistant professor of pediatrics at The Ohio State University College of Medicine. Dr. Gaw will be followed by Bridget Duffy, who is a senior research associate at the Center for Injury Research and Policy at Nationwide Children's Hospital. We'll then hear from Dr. Laura Seawald, a clinical assistant professor of emergency medicine and research assistant professor with the Institute for Firearm Injury Prevention at the University of Michigan. And then finally, Dr. Heather Hartman, a pediatric surgery research fellow at the University of Michigan, will share about her important work. Thank you all so much for being here. I'm excited to hear from our researchers, and I will give it away to Dr. Gaw.
Hi, everyone. Thank you all for being here and thanks for the opportunity to speak with you guys today. I am going to pull up my slides. All right, and we can get started. So today I'm going to be talking to you guys about opportunities and challenges in characterizing poisonings using child death review. And for my portion of this session, I really have two goals for our audience today. The first is I want to describe how child death reviews can really improve our understanding of pediatric poisoning fatalities and how the NFR-CRS fits into this framework to really enhance our knowledge in this space. And I really also want to highlight how this study that I'm about to present was primarily exploratory and descriptive and relatively simple in design, but really powerful and impactful. And it's a great way to utilize and get acclimated to NFR-CRS data. And then the second part, or the second goal of this talk is really to share some challenges that we faced as our research team as we worked through this data, specifically with relationships to fatal poisonings. So for a little bit of background, when we think about poisonings, I think many of our minds float to or go to the opioid epidemic that's currently affecting our country today. And oftentimes that involves older individuals, adolescents, and adults. However, we also see poisonings in young children, and young children are at increased risk of poisonings due to multiple different factors. Young children have developmental behaviors where they like to put things in their mouths. There's an added layer where there's a dependence on the safety of the home environment and a reliance on care being provided by guardians or supervisors that can really change a child's risk profile. And we've seen how important that is and how public health efforts can really affect the safety of children with respect to poisonings and ingestion. This graph, I think, gives a really good sense of how far we've come as a country in terms of preventing fatal poisonings. And so if we look back at 1970, that was when a hallmark public health law was passed called the Poison Prevention Packaging Act. And that act really standardized how consumer products and medications were labeled, packaged, and stored so that they were less accessible to young children. And in the years following that act, as that regulation rolled out and as industry adopted those regulations, we saw a precipitous drop in pediatric poisoning fatalities among young children, specifically under the age of 6. And so, however, as time went on, we could see that throughout the 1990s, 2000s, up through the 2020s, that trend of fatality reduction has plateaued. And the graph that I'm showing here was compiled by the Consumer Product Safety Commission, which primarily uses ICD codes stored in death certificates to identify fatal poisonings. And there is a limitation to that because that requires a clear recognition during the death certificate process and a clear labeling using a specific ICD code for a specific type of poisoning. So for example, if a child was characterized as a cardiac arrest or a respiratory failure or a suffocation, for example, even if a poisoning or a substance was involved in that death, it wouldn't necessarily be characterized or captured. And so this is likely an underestimate of the true number of fatalities that we're seeing in our country. And so death reviews provide us an opportunity in two ways to really tackle this fatal poisoning issue and improve the depth of our understanding. And so the first is that it provides a different lens because child death reviews really go into rich, deep, and diverse data to really understand the background behind a fatality. And child death reviews also have a specific subsection in H7 of the case review or case reporting form, which captures specific substances involved in a poisoning fatality. And child death reviews really provide complementary information to existing data sources. So death certificates are often focused on clinical and demographic factors. There are several toxicologic databases that really focus on substance factors and clinical toxicology related factors. And child death reviews are complementary to that in the fact that they really dive into the social risk factors and the environmental factors that may not necessarily be captured in these other databases. So we embarked on this study that was published in Pediatrics in early 2023 to really characterize fatal poisonings among infants and young children in the United States. And at the time, the NFR-CRS had not yet been utilized to really look comprehensively at poisonings in this age group. So our study objectives were to describe the demographics, and demographics is being defined broadly here, of fatal poisonings in children less than to equal to 5 years old. And as a secondary objective, we also wanted to characterize the proportion of deaths from opioids, knowing that the opioid epidemic is a major factor of morbidity and mortality in our country. Note that we focused on proportion rather than just numbers because of the earlier limitation that was discussed about the fact that the NFR-CRS is not necessarily a nationally representative sample. However, we felt that proportions would give a sense of the general capture of what people were focusing on or seeing in their respective communities as they underwent the review process. And so we requested data from the NCFRP from 2005 through 2018 for the age ranges that we specified. And we requested data broadly. So we were interested in poisonings on a broad scale, even though our secondary objective was focused on opioids. So we requested deaths from any poisoning, overdose, or intoxication. The variables we analyzed were quite broad, so we focused on demographic characteristics. We were also interested in supervisor characteristics because young children are often supervised in some fashion, and supervision is an important aspect of the mechanism of injury or mechanism of poisoning leading up to a poisoning event. We also queried incident characteristics, death investigation outcomes, and then there's a specific section, which I'll show you the case reporting form, of poisoning-related variables, which provide information on not only the substance, but aspects of the substance and substance storage. So of the over 2,600 variables in NFR-CRS, we actually queried about 100 or 200 of those variables, and we took a deeper look at them. So in the next phase, I'll present a couple of data challenges that we encountered once we received the data, and I'll kind of batch them into kind of three main themes. The first is data missingness. And so child death reviews work with the data that they have, the information that they're able to collect during the death review process. And they may not have all that available data for every single case, for every single variable. And so what we discovered as we started to look through the data that we received is that there was varying levels of missingness for certain or specific variables, such as aspects of the incident, in terms of supervisor demographic and social characteristics. So we had good information on the child. We had decent information on the primary supervisor, but there wasn't as much detail or as much completeness of the data on the actual demographic, social, and risk characteristics of the supervisor. We also saw that there was varying levels of information available with respect to substance container and storage, which are important variables when we're thinking about mechanism of injury. And then certain child social factors were also incompletely populated. And so this begs the question of how do we handle that missing data? And so we had discussed several potential avenues, whether we present the data in its completeness in terms of what we had, making it clear what was missing, versus considering potential multiple imputation methods, some more advanced statistical methods to see if we can extrapolate from the data that we had. We ultimately decided to focus on the former, so just providing clear, transparent numerators and denominators of the percentages that we were presenting and clearly identifying what was missing. Because again, multiple imputation requires some level of trust and understanding of the data that you have, and we weren't able to really know for sure if the data that we're extrapolating from or imputing from was biased or not. And so we left it up to the readers to really work with the level of missingness to have them draw their own conclusions based on what we were able to present. The next theme that we saw was that when we dived into poisoning variables, that it did require some level of cleaning and recoding. And so I'm going to show you the H7 section of the case review form. And I'll add the caveat that when we analyzed the data, the NFR-CRS was still on version 5. So this form will look different for investigators who are interested in looking at poisonings today because the form has changed. But you can see that child death reviews have the opportunity to specify different types of medications. And as you kind of scan through, you can see how these medications are characterized, and child death reviews can also check all that apply in that situation. And so from a administrative database analysis perspective, check all that apply can be a bit challenging to kind of characterize, summarize, and present. And so that was one of the challenges that we encountered. At the time, the way that the case report form was set up was that child death reviews could also specify or write in different types of medications, over-the-counter medications, illicit drugs, or even other substances. And so this created an entire set of free text variables that we opted to go through manually and recategorized. And so you'll see in the paper that we referenced that we actually went through and recategorized all of these variables to create substance categories that potentially can inform injury prevention efforts. And I just want to point out too that there are various aspects of that H7 form that are really important and helpful in poisonings or understanding poisonings. And so we also looked at these as well. But as mentioned before, there was varying levels of completeness for some of these variables. And I think the third theme or third challenge is that there's occasionally nuances in interpretation of how child death reviews code and present or report their data. And I'll give you a couple of specific examples that we encountered. So we were interested in maltreatment history as one of the variables of social risk for the patients who are presenting with fatal poisonings. And we could see that if you look at the data dictionary definition of maltreatment history in the NFR-CRS, it refers to a CPS referral, substantiation, or law enforcement medical record or autopsy report. So we wanted to make sure that that was clear as we were presenting it, because obviously maltreatment history could mean different things to different people who may not be familiar with that definition. Similarly, circumstances of poisoning is another variable available. And so some of the categories include accidental overdose, deliberate poisoning, or another cause. And there's some subjectivity in that interpretation, and that subjectivity is allowed by child death reviews based on the information that they have. And so being able to communicate that to a research audience of understanding that there may be subjectivity in that interpretation is also important. And so that was one of the things that we faced as we worked through our data analysis and the presentation of our results. And finally, as alluded to earlier, the substances contributing to death is another area of nuance and interpretation. And so child death reviews have leeway to specify what substances were involved in a child's death, but that doesn't necessarily mean that the substance truly caused the child's death. And again, there is some subjectivity in that interpretation. And so we chose to report our findings as substances potentially contributing to death or substances contributing to death as identified by child death reviews. So in the last few minutes, I'll briefly present some of the key findings from that paper that we published. We were able to identify 731 poisoning-related fatalities reported to the NFR-CRS from 2005 to 2018. We saw that the youngest children were disproportionately represented. So of our study population, 42% of those 731 fatalities were under 1 year of age, and then 24% were 1 year of age. So over half were under the age of 2. And we also saw that child death reviews identified that opioids were the most common contributors to death. So 346 fatalities involved opioids, and 210 of those 346 involved children 0 to 1 year of age. And interesting enough, the second most common category, which was over-the-counter pain, cold, and allergy medications, there were 108 fatalities, of which 80 of those involved that 0 to 1 year of age group. Important to note, because of that check all that apply situation on the case reporting form, this is not per case, but this is just the total number. So child death reviews could report more than one substance contributing to death for each case. And we saw that the proportion of opioid-related deaths was increasing. So this was reporting on our secondary objective. And we saw that child death reviews identified about 24% of the proportion of substances contributing to death in 2005 as related to opioids. But by 2018, that number was 52%. And so this descriptive hypothesis generating study really was able to allow us to comment on multiple aspects of injury and poison prevention. We were able to highlight importances in terms of prevention counseling, the importance of naloxone prescribing, and we discussed opportunities for policy and advocacy in our paper in conjunction with the evidence base that we were able to present through the NFR-CRS. And so in closing, even though this was a relatively straightforward exploratory study, again, it was quite impactful and allowed us to really jumpstart the conversation on how young children could be harmed with fatal poisonings. And with that, I'll thank you all for your time, and I will stop sharing and turn it over to Bridget.
Thank you, Dr. Ga, for that great talk. I will share my slides now. Here we go. Presenter view. Oops. Here we go. Okay, good afternoon, everyone. My name is Bridget Duffy. I will be talking about the study titled Characteristics of Fatalities Among Sexual and Gender Diverse Youth in the US from 2015 to 2020. And my goal is for you to get a glimpse into the methods we used in this study and perhaps spark ways you could utilize data from the NFR-CRS. Similar to Dr. Ga, the study was mainly descriptive and relatively simple in design, but we did use matching as a method to help us make comparisons, which was a really powerful tool, and I'll be focusing on that a lot in this talk. I have no financial relationships or interests to disclose. So some context, sexual and gender diverse youth face a myriad of stressors that negatively impact health and well-being compared to their heterosexual and cisgender peers. SGD youth often encounter discrimination related to their sexual orientation and gender identity at home, in school, and throughout society. We know that SGD youth are at elevated risk for dying by suicide compared to their heterosexual and cisgender peers. Research on mortality of any cause among SGD individuals has been extremely limited due to underrepresentation in national health surveillance data due to difficulties collecting this information during death investigations. At the time, we were thinking of utilizing an NFR-CRS to study SGD youth fatalities. Data from the NFR-CRS had not yet been utilized for this. So our aim was to epidemiologically describe deaths among identified sexual and gender diverse youth and compare their characteristics to a matched sample of youth from the same data who were not known to be sexual and gender diverse. To define SGD youth, we used the existing variables child's sexual orientation and child's gender identity. A child was considered SGD if their sexual orientation was reported as gay/lesbian, bisexual, questioning, or other specify, or if their gender identity was reported as transgender male, transgender female, non-binary, or other specify. Criteria defining the non-SGD matched comparison group were a sexual orientation of straight/heterosexual and a gender identity of either male, not transgender, or female, not transgender. So we worked closely with the data team at the National Center to understand the availability and limitations of data on SGD youth fatalities when we had this idea. A key challenge was the history of gender identity and sexual orientation variables, which were removed in 2018 and reinstated in 2020 with some expanded response options. Although earlier data weren't crosswalked, some states updated records retroactively back to 2015, allowing us to include those cases in our study. At the time of our data request, 2020 was the latest year available. To strengthen our analysis, we employed a matching approach. After discussions with the data team, we established criteria for matching one SGD youth fatality to two non-SGD youth fatalities by age, year, and race category. The National Center then used our criteria to identify SGD youth fatalities and match them to non-SGD youth fatalities before providing us with the dataset due to restrictions around narrative release. Analysis was done using SPSS. We reported basic descriptive statistics with frequencies and percentage and used chi-square tests to perform comparisons between proportions of characteristics between groups. A look at our study population, we ended up having 176 SGD youth and 352 non-SGD youth deaths. We requested child demographic, incident, investigation, history, and life stressor variables. Cell counts less than 6 were suppressed, and variables with more than 50% of missing data were not reported in our study. To facilitate matching and due to small numbers, various race categories that you can see here on the slide had to be collapsed into an other category. Now we'll talk about some strengths of using matching, particularly in this study. One is improved comparability. Matching on age and race was a key methodological choice to strengthen comparability between the SGD and non-SGD youth groups. By controlling for these demographic variables, we could focus on identifying meaningful characteristics in other characteristics. Two is addressing the small sample size. One of the challenges with studying SGD youth fatalities was the small sample size here. The matching approach allowed us to make the best use of available data while maintaining the integrity of our comparisons. Next, reducing bias. By accounting for age and race through matching, we aim to minimize the risk of bias that could distort our findings and ensured that observed patterns were more representative of the actual differences between groups. And lastly, enhanced analytic rigor. From a methodological perspective, matching provides a structured framework that enhances the validity of descriptive analyses, especially when working with diverse and complex data sets. Next, I'll talk about some considerations for using matching, especially if you may consider using matching in some of your studies. One is variable selection. The choice of the variables you match on is a key consideration. Including too many variables might lead to overmatching, which may mask real differences, while too few variables could fail to account for confounding factors. And sample size trade-offs. In this study, we wanted to focus on maximizing our SGD youth fatality group. The data team at the National Center explored various other options for the variables we could have matched on, such as not combining race categories, and we had to identify the option that maximized our SGD fatality sample and also matched on meaningful factors. So it's important to balance criteria stringency with the availability of comparable cases. And missing data. Handling missing data and key variables is critical because it can affect the pool of available matches and potentially introduce bias if you don't address it carefully. And evaluating balance. After matching, it's important to assess whether the groups are truly balanced on the selected variables. This can be done using metrics like standardized mean differences to confirm the success of the matching process. And now I'll just very briefly give you an overview of some of the key findings from our study. Here you can see the breakdown of gender identities of SGD youth, the 176 SGD youth in percentages here. And here you can see the breakdown of sexual orientations of SGD youth. 45.1% of SGD youth were identified as gay/lesbian, 23% bisexual, and nearly 25% were questioning. A striking finding was that the majority of SGD youth died by suicide at 81.4% of SGD youth, compared to 53.5% of non-SGD youth. And here are some history and life stressor variables that we looked at among deaths of youth who died by suicide in both groups. So a smaller proportion of SGD youth, you can see here in purple, were involved in sports. Greater proportions of SGD decedents were a victim of bullying, had a history of self-harm, and were diagnosed with a depressive disorder. And for nearly a quarter of SGD youth, there was evidence that they had experienced stress due to their gender identity. And for nearly a third of SGD youth, there was evidence that they had experienced stress due to their sexual orientation. Now, some limitations. Reporting bias is likely as many SGD youth disclose their identities first to peers rather than adults contributing to CDR records, leading to potential misclassification, and a lack of standard methods for recording gender identity and sexual orientation during death investigations, along with differing acceptance levels of SGD youth across the US, exacerbates underrepresentation. And the small sample size required for combining sexual and gender diverse youth for most analyses, or the small sample size required us to combine those groups. However, stratifying those subgroups whenever possible would improve insights and should be done when you can do it. And implications for future research, the methods used in this study, particularly matching, offer one example of analyzing underrepresented populations like SGD youth when faced with a relatively small sample size. They also highlight the critical importance of consistent data collection on gender identity and sexual orientation. To improve future research, there's a clear need for better training and standardized approaches for documenting SGD status in death investigations, which would help reduce reporting bias. This is not specific to NFR-CRS data, but a challenge for all data systems that capture this information. And matching techniques applied here can also be used in studies of other populations you may be interested in studying, making this approach broadly applicable. And lastly, the NFR-CRS is a valuable resource for researchers. Its centralized data and support from the National Center makes it possible to conduct nuanced and impactful analyses. As this data system accumulates more years of data, the variables that capture SGD information, I think it will be very important to continue focusing on these variables in future studies. And thank you. Here is my PI and my other lab mates who worked on this study with me. Thank you. And I will pass it on to the next speaker.
Hi, everyone. Just let me pull my slides up real quick. Okay, great. Well, so thank you everyone for inviting me to talk with you all today. My name's Laura Seawold, and again, I'll be chatting about some of the data we use from the Child Death Review team. Specifically, I'll be talking about childhood firearm deaths during intimate partner violence incidents with data spanning from 2004 to 2020. I don't have any financial relationships or interests to disclose. And so similarly, I will kind of go through this work in terms of talking about some background around IPV incidents during childhood deaths, methods overall, results and conclusions and discussion, and kind of highlighting some of the limitations we found to the data during our kind of as we were going through it. Similarly, to the other presenters, a lot of this was kind of more descriptive in nature and helped our team basically get familiar with the data. and we plan to kind of do some additional analyses that we'll talk about as well. So as background, intimate partner violence is really defined as physical violence, any psychological aggression, sexual abuse, and stalking that occur in any current or former intimate relationships. And we believe it is a public health problem that impacts children and adolescents both directly and as collateral victims. We found that about over 15 million children in the United States are exposed to IPV annually, and 6 to 10% of all violent pediatric deaths are IPV-related incidents. Additionally, the presence of a firearm during an IPV encounter increases the risk for fatal outcomes fivefold, and firearms are also the most common mechanism of death during childhood IPV incidents. Previous work in around childhood IPV deaths in other systems have been done, but no one has really examined the incident details that might differ between firearm and non-firearm childhood related deaths or childhood IPV deaths. So the goal for this work was to describe some characteristics of childhood firearm IPV deaths and the differences between firearm and non-firearm childhood IPV deaths during or using the NFR-CRS data. So again, this was data from 2004 to 2020 for ages 0 to 18 years old who passed away as reported from 37 states, and our total N was 464. I will be talking about some descriptive analyses we did around the child's demographics, the mechanism of death, providing some incident details, and firearm characteristics. Also, we'll discuss some unadjusted logistic regressions for bivariate comparisons of firearm versus non-firearm childhood IPV deaths. And then also, we did look at child maltreatment history, IPV victimization history of the child, as well as open child CPS cases and the number of deaths during an incident. But they were not included in our bivariate analysis due to the missingness of the data, but we did describe. So first, we want to define what an IPV incident was using this data. And so basically, deaths were included if the mechanism of death was identified as bodily force or weapon, so something like a firearm, and the mechanism of intent included IPV. So here you can see on the left that bodily force was one of a few different mechanisms of death, and that the weapon at the time, use of the weapon at the time could be from a variety of things, and we focused on intimate partner violence. So one limitation here was, while a history of intimate partner violence for either the child, a caregiver, a few other people who are related or have relationships with the child are present, the only way we could look at if IPV was related to the cause of the injury was through the bodily force or weapon component. And so you can imagine that if a child was drowned, it could have been also during an intimate partner violence incident, poisoning or other intoxication or some other injuries. So we may be missing a subset of people who passed away in a different way, or who passed away during an IPV incident, but may not have been classified. We also did want to examine some weapon and firearm details. So first, of course, in the interest of this analysis, we looked at what the type of weapon was, firearm versus knife or other sharp instrument, rope, or another object, and then unknown. And here we ended up combining rope and other weapon just because of the small amount that occurred in those categories. We also wanted to look at the firearm type that was used during the incident, including handguns, shotguns, rifles, or 3D guns. There was also a little bit of data there about whether the firearm was kept loaded. There was also some data that I didn't present here that shows whether the firearm was stored locked and whether the ammunition was stored separately. But there's pretty significant missing data there, so we ended up not reporting on that. But we did want to just highlight at least one of these things, and we chose to highlight whether the firearm was kept loaded. in the house, or kept loaded in general, I should say. And then we wanted to know who the owner of the firearm was and whether that was the caregiver, some other family member, a child, significant other, friend or acquaintance, or stranger, or someone else. And then looking at some of the other incident details, again, we wanted to see if we were interested if the child had a history of maltreatment as a victim, if there was an open CPS case at the time of the death, whether the child had a history of intimate partner violence. And so there's a few options here, but we focused on if they had had any history of victimization specifically. And then also one thing we really wanted to look at as well was the total number of deaths at the incident event, including the child, both for children and adults. So hopping into results here. So firearms were the most common mechanism of death during these childhood IPV incidents, and the total N was 300, which accounted for about 65% of the sample. This was followed by bodily force, which was 19%, using a knife or a sharp object at 17%, other weapon, including rope, was 7%, and then unknown for about 2%. Looking at some of the other incident details, we found that 43% had prior maltreatment reports, about 37% had prior IPV victimization reports, 8% had open CPA cases at the time. And then another thing we found interesting was there were overall higher numbers of deaths during an incident when a firearm was used, with about 3 deaths during that incident compared to other mechanisms, which was about 2. But interestingly here is while the overall number is higher, you do see that there is often more than 1 death regardless of the mechanism, meaning that, again, these kids are typically what we call collateral victims, so may not be the initial target during the incident, or they might be a part of it, but that usually more than 1 person is going to pass away during these events if the child is involved. And then looking at just some information around the firearm details themselves, we found the most common type of what firearm used during this incident was a handgun, 70%, followed by shotguns and rifles. We didn't really see any 3D reports at this time, and then there was some unknown as well. And then in terms of whether the firearm was kept loaded, there was about 11% reported yes, but again, this is kind of where we get into some of that substantial missingness, which is that about 75% were unknown or not specified. So the majority of the sample for that variable. And then looking at who the owner was of the firearm, almost 60% of the time it was the the primary caregiver. 5%, 4 or 5% of the time it was another family member or the spouse / child's significant other, sometimes a friend or acquaintance. And then we also had about 20% that were unknown. This table represents some bivariate comparisons of IPV incident deaths when there's a firearm versus another mechanism of death. And this kind of examines some more of the child factors themselves. So we looked at age, we looked at sex, and then race and ethnicity, and found that children who died in an IPV incident with a firearm compared to another mechanism were more likely to be older. This is a similar comparison, only this time we're looking more at some of the incident details themselves. And here we looked at location. So if this was in the home versus somewhere else, we want to know the area type. So if urbanicity or suburban or rural had anything to do with whether a firearm was used or not. And then we also wanted to see who the primary person was responsible during the incident. So a parent's partner, child's partner, or someone else. And here we found that the parent was more likely to be involved, the primary person responsible for the child's death during an incident, than other people that the child has a relationship with. So in terms of discussion, this data set really demonstrated that firearms are used in most childhood deaths related to IPV incidents. and that when IPV incidents involve a firearm, that more individuals are harmed and that the parents are often involved. So this highlights that in addition to IPV interventions providing education on safe and healthy relationships, creating safe environments, and providing strategies to leave abusive relationships when safely feasible, that interventions should also include components of safe firearm storage and counseling, and discussions about how to limit firearm access, including domestic violence restraining orders. Additionally, about 8% of decedents in the sample were known to have an open CPS case at the time of their death, and about 40% also had reports of previous maltreatment or IPV victimization, suggesting that there's some potential for service agencies to intervene early to prevent lethal escalation of family-based violence. Some of the limitations I highlighted a little more specifically to this study, but of course, some of the limitations were broad, and we've already talked about what those are. But for us, we want to really look at some analyses in the future that examine the case narratives to give a little more context of factors that may contribute to IPV incident deaths. Not only will those case narratives give us more context around the deaths themselves, but they might also allow us to identify some cases that may not have fallen into the initial algorithm for how we identified IPV incident deaths using this database. So that was kind of where we hope to go with this work. And with that, I thank you for your time. You can email me here if you have any questions, and obviously happy to take questions at the end. And I will pass it off to Dr. Hartman.
Thank you, Dr. Seawald. Let me just pull my slides up now. All right. So I'm going to follow Dr. Seawald and discuss contextual factors influencing firearm deaths occurring among children. I have no financial disclosures. I was previously at the University of Michigan. I've now moved to Nemours Children's Hospital in Delaware, where I'm doing a clinical fellowship. So I'd like to, running through the plan for today, we're going to talk about the original analysis that we intended to do for this project, and then discuss some of the problems that we found within the data set that made the original analysis challenging. And then we'll move on to how we pivoted and found a new way to use the data to answer questions that we were kind of asking, and use what we have. And then finally, I'll present the analysis that we had and focus primarily on the results related to the cluster analysis for it. So first, we'll start with our original question. We set out originally to describe how children of different ages die from unintentional firearm discharges, and to describe the differences by age group. And the children were broken into 3 age groups based somewhat on developmental stage, including children less than 5, those 5 to 10 years of age, and those over 10 years of age. The first thing we needed to decide in our analysis was how to define unintentional firearm discharge. Frequently, when we look at analyses, manuscripts that are out there, the studies will examine unintentional deaths using medical examiners' official cause of death to determine the intent. And that is most certainly included in this data set. The next question for the official manner of death section asks about the primary cause, which includes bodily force and weapon, as Dr. Seawald mentioned. And then within the bodily force and weapon section, it specifies a firearm. So defining this category is relatively straightforward in that regard. When we look at the official manner of death for firearm deaths, we see that the expected transition from mostly accidental deaths to mostly homicides as we go up in our ages. The challenge with using the official manner of death is that homicide and accident are medical legal terms that classify the classifications vary across different medical examiners and jurisdictions, and
within investigation practices and also based on racial and age-related biases. And so review of pediatric firearm deaths data suggests that unintentional firearm deaths are actually underreported when we use the classification of accidental from the official manner of death in a death certificate. Alternatively, we said we could determine unintentional deaths by the firearm uses at the time of death. Examining the uses database, we initially identified 6 activities that were likely unintentional, and those included hunting, target shooting, playing with or showing a gun to others, cleaning a firearm, and loading a firearm. We also included Russian roulette as an intent, as the intent behind Russian roulette is not usually suicidal. It's more of children playing with taking risks and not intentionally killing themselves. When we ran this initial analysis, we had almost 1,500 unintentional firearm deaths in the database, with the majority resulting from playing with a firearm or showing a firearm to others. So that's fantastic, but now we looked at the other firearm uses that were described when we looked at those children, because it's not mutually exclusive. And additional firearm uses were noted, and that could be potentially problematic. Almost 14% of child firearm deaths of an unintentional nature were noted to be self-injury uses of the firearm. And while this could be that the child injured themselves resulting in a death, it could also be that this is a suicide, or that someone else was intending to injure themselves and accidentally killed a third party who is our victim. The other questionable firearm uses that occurred to a lesser extent in our data set included commission of a crime. It included gang-related bullying, intimate partner violence. And when we looked at this, we said, well, commission of a crime, is that there's a crime that the firearm was left unattended and a child found it and shot themselves or another person, or is it that they were in a drug deal and that drug deal went bad and a firearm was used and they died? And you can't really tell from this part of the data. And additionally, 7% had other firearm uses that were not specified. And there is text to go along with that when it gets entered, that people are able to enter additional information. So we turned to our data dictionary to see if we could safely exclude any of these cases that looked problematic. While the data dictionary generally gives helpful definitions for each item, the definition for use of firearm does not clarify for any of the firearm uses. So we reached out to the NCFRP, and they confirmed that firearm uses had several potential interpretations, and that going forward, they would be addressing this definition with further clarifying for data collection. So while this is a challenge for our current data, it will hopefully be resolved in future data that's collected. We also noticed that there was variability, as has been previously mentioned, in the completeness of the data, with certain items being nearly always complete, such as the child's age and their gender, while other items were largely complete, and that would include things like urbanicity and the supervision of the child at the time of the incident. And then other items had much higher rates of missing data that included information about the second primary caregivers, the firearm storage situation, if it was locked, if it was loaded, and who the firearm owner was. There was a lot more missing data for those items. So at that point, we concluded that we couldn't answer our original question. How do children of different ages die from unintentional firearm discharge? Because we couldn't confidently answer the question of what was an unintentional firearm death. One of my colleagues, who was very persistent, kept suggesting that we look at a cluster analysis to let the data tell us the story. A cluster analysis, this may trigger some biology for folks, is an exploratory data analysis technique that's used to identify natural groupings and clusters within data sets. The one that you're probably familiar with is taxonomy tree that's used in biology that shows the relationship of animals or plants to each other in a hierarchical manner. Cluster analysis can also be used in medicine to identify patients with similar symptom patterns to target treatment plans. For those who, like me, had never done a cluster analysis and truly really had never read a dendrogram, there's a really great resource that's on the top of my page, this QR code up here. That was a really nice, simple walkthrough from Wheaton College on how to read a dendrogram. The cluster analysis results in a dendrogram that's shown how things group together, and these groupings or clusters are called clades, and they're composed of related characteristics. So these are our clades. The terminal ends of the clades are leaves and represent the individual characteristics that we're examining. The height of each branch tells us how closely related leaves are to each other, with shorter branches being more closely related and longer branches being more distantly related. Reading from the bottom up, items 1 and 2 are more similar to each other because they have shorter branches than items 4 and 5. And then items 1, 2, 4, and 5 are more related to each other in this dendrogram than item 3. Item 3 is our outlier, having very little relationship to the other leaves and clusters in this dendrogram. So in order to do a cluster analysis, the data must be complete. We decided that to perform our cluster analysis to examine firearm deaths of children, we would do children ages 10 years and younger, with the thought being that there's a significant shift in the types of firearm deaths as children age, with more suicides and homicides in older children, meaning that the areas for injury prevention would likely be different in preteens and teens than it was in younger children. So in performing a cluster analysis where the leaves have very low N, it makes it very messy and hard to interpret the dendrogram. So in order to address this, we took related uses and merged them, such as playing and showing a firearm, child abuse and intimate partner violence, argument and jealousy, drive-by and random, cleaning, hunting, and target shooting. Firearm uses that were less than 1% of the sample, such as self-defense, were reviewed for co-occurring firearm use patterns and characterized using those higher frequency options. And then the other firearm use comments were reviewed for recategorization of the deaths into existing firearm use categories. This review of the other resulted in us identifying an additional firearm use, which was murder-suicide. And so that brings us to our final analysis. The final cluster analysis included 1,167 children 10 years and less who died of a firearm between 2004 and 2021 in 41 states and had complete cluster analysis variables. The majority of these deaths occurred in the child's home or in a friend or family member's home. Most incidents involved a handgun, and the 3 most common firearm uses were crime, playing and showing a firearm to someone, and self-injury. A notable 110 cases, or 9%, were murder-suicides, and in 188 incidents, or 16%, there was noted to be child abuse or intimate partner violence during the firearm death. So this resulted in a cluster analysis with 6 distinct clades. Gang-related drive-by and random shootings that happen outdoors, long guns while cleaning, hunting, and target shooting, bystander child firearm deaths during IPV, abuse, and arguments and jealousy, supervised deaths in the child's home with a handgun, and a crime may have occurred at that same time. Again, remember, negligence could be that potential crime. Murder, suicide, and self-injury also in the home, and unsupervised playing and showing of a firearm to a friend in a friend or a family home. So the first 3 clusters can be grouped as related to unintentional causes. This is the unsupervised playing and showing, long gun cleaning, hunting, and target shooting, and supervised handgun use. And suggests highlights the importance of the child's developmental stage when we're considering firearm access and secure storage, and the need for careful supervision during firearm use. The clusters, these 2 clusters, child abuse, IPV, and murder-suicide, raise concerns about violence within the home. Situations where CPS is involved or there is identified intimate partner violence represent missed opportunities to prevent firearm injuries and deaths. And this is a place where providers and child protection service workers are critical in identifying the intimate partner violence and providing education to families about safety planning and the benefits of locked storage, and also safety planning for escape. Sorry, I said that, safety planning for these dangerous situations. And then the final cluster of community violence highlights the impacts of societal redlining and the economic disinvestment in communities, and thus a need for multi-level approaches to prevention. In this group, individual level HVIPs, health violence injury prevention programs, employing behavioral therapy combined with referral to resources demonstrates efficacy in reducing violent aggression and victimization. At the community level, greening and vacant lot remediation reduce firearm violence by creating busy streets. And when you combine this with policy-based initiatives to address economic disinvestment and enhance employment opportunities, these interventions may be effective to reduce community violence and bystander child firearm deaths. And so I just want to thank you for listening to me. And here are my emails, both my Michigan and Nemours email. I check them both routinely. And I'm happy to discuss further.
Thank you so much. Before we get into questions, like a quick little silent round of applause for all of our researchers. I was so excited to put this panel together because I think it really demonstrates the versatility of child death review data. We were able to see how research can happen across different topics, and how inherent limitations, like any data source, can be addressed and still find great value and meaning. And I wanted to call out that I love seeing how the findings tie back to our really key tenet of prevention and fatality review. So thank you so much. Before I just jump into questions, I wanted to open up to folks who are here with us. Feel free to throw your hand up and take yourself off mute, or put your questions in the chat for our presenters. Don't be shy.
Well, I have a question.
Yes, please.
I would love to hear more about, so Sasha, you mentioned that some changes had been made to the definitions based on this last study. So can you tell us more about what changes you guys made?
Yeah, definitely. On one of the links that Kristen shared a little bit earlier, is to our webpage for the case reporting system itself. So there's a variety of information on there. I'm going to drop directly in the link to our current data dictionary. So that will show you all of the variables that are collected in the case reporting system and our current definitions. It's quite the document, but if you go to page 71, whereas Dr. Hartman showed on her slide that it used to just say, specify the intended use of the weapon, and that was it, we've now included a brief definition for each use. So Dr. Hartman really highlighted how self-injury initially came up as sort of another use of the weapon that had been selected by fatality review teams with deaths that her team had initially thought would be unintentional. And what we were finding by looking a little bit deeper into those circumstances of those deaths was that, just like she mentioned, it could have been a different circumstance where the intent was not a suicide, but someone still injured themselves. So self-injury was somewhat misleading to folks completing data entry in the case reporting system. And now we very specifically say to select self-injury only if the use of the weapon was intentional, so a suicide death. And so you can kind of go through and look at, we just really wanted to make them more clear for each use of weapon, why you should be selecting each one. And what's great, I'll just kind of throw in a plug, which aligns with what I shared during Dr. Gau's presentation, is that at the National Center, we want to make sure that the case reporting system is flexible and responsive. So we have it slated about every 18 months that we make improvements to the system, whether that be to variables themselves. We might remove variables that no longer serve the field of prevention. We might add variables that are new. So random examples that are coming to mind are, we added to the motor vehicle section to be able to collect information if it was an electric vehicle or an autonomous vehicle. We also added variables to collect information when the COVID pandemic started, to understand how the pandemic was impacting children and their families. So we are continually making improvements to the system and also to our supporting documents like the data dictionary. So we hear from researchers like Dr. Hartman and really want to be responsive. What other questions do y'all have for all of our presenters? I will throw out a question. It is general, and anyone can pick it up and you can pass it along. What did you find to be rewarding about your research using these data? And if you didn't, that's okay too.
I can go ahead and start. I mean, as someone focused kind of on firearm related deaths, I thought this data was pretty rich in terms of, there was a lot of actual analyses we were interested in, including the one that I did, the one Dr. Hartman did, and then Eugenio, who actually published it as well with this data. But there was also just a lot more kind of things that we wanted to look at and explore. And so, like I said, we're kind of also getting excited to look at the actual more detailed reports to kind of even get more, even richer data through those narratives, which I think will provide a lot of additional context to just how children are, dying in general, but also as they are related to like firearm related incidents specifically.
Dovetailing on what Dr. Seawald said, really found it very interesting getting to learn more about the specific types of deaths and all the richness of the firearm death variables. But I also really enjoyed the process of getting to the analysis that we ended up with, because we really did have a large pivot, as I mentioned. And when you get, sometimes someone tells you, try this method, you've never heard of it before. It's really scary to say, okay, I'll take this jump and leap off this cliff into some analysis type I've never done before. But try it, it's fun. And sometimes it works.
And just thinking about this for me, I think there are multiple aspects that felt really rewarding using fatality review data. One is just how collaborative it felt working with folks at the National Center. We had a lot of questions at the beginning when we were planning our study, and we met with folks in the data team several times to discuss options, what would be best given the data, since it was our first time working with it. And that was just so helpful to feel like we had someone to ask questions about the data too. And also just a sense of responsibility that comes with working with fatality review data, I felt to be very impactful. Each case represents a child's life, and it's incredibly impactful work to work with these data, knowing that behind every number is a young person who had their own story and challenges and potential. And that perspective really drove me to approach the work with a lot of care and intention.
I think for me, I found the entire process extremely rewarding, and it's amazing to collaborate interdisciplinary in terms of not only working with the National Center, understanding the data, helping to really be able to tell these children's stories so that we can prevent future deaths. But it's amazing how this data, especially for those who are not familiar with it, is equally powerful. And so I think, when we worked through this work and started to present it, there were entire fields that were really interested and excited about understanding this data and then incorporating it into their practice prevention and advocacy methods. So it's really cool how this is truly a bridge, like even though these are tragedies and these are tragic deaths, to really bring together our scientific community to be able to try to make the world better.
Thank you all. I think that's really telling, and it is notable that I think all of you, after your initial sort of look, your initial research question where you use fatality review data, each of you has figured out what can I ask next, and the work continues, and it just shows how we're honoring these young people. I know that each of you briefly mentioned towards the end of your presentations how your findings connected back to prevention. There is a question about, have the data directed policy in any spaces? And if you'd like to share.
Thinking back to our work, I don't know if there's been any direct change yet, but I do think that there has been a lot of awareness, not only amongst the academic community, but also in terms of the policy community. I'll give you a concrete example. So after our work was published, it was actually brought up by the FDA as part of a National Academy scientific panel looking at drug disposal methods and really convening multidisciplinary stakeholders to try to figure out, is there a way to incorporate drug disposal practices to not only help adolescents and adults in the opioid crisis, but also to protect younger children from unintentional opioid exposure. And so seeing that the NFR-CRS data provided some of that evidence base to really inform the discussions is really cool, and to see that translation into that policy space.
Yeah, so, we haven't, again, seen any direct links to this in terms of, preventing firearm-related deaths during IPV incidents. But what we hope is that as other states think about expanding their, red flag laws or their DVRO laws, that they can kind of refer back to this information to help kind of show that not only are you protecting the people who are in that relationship, but also more broadly speaking, that some collateral victims, as we say, which in this case would be children. And that adding firearm provisions to those sorts of laws are really important in keeping not only the people in those relationships safe, but also people surrounding those relationships safe.
At our institution hospital level, the institution has started to approve policy-wise more counseling and offering of storage devices to families who own firearms. But as Dr. Seawald said, so far we haven't seen policy level changes in terms of firearm safety, and I anticipate that that will be a very challenging area, as it has been for years.
Thank you all. I'll just add, in addition to the research that we heard about today, fatality review data have been used to direct policy. A large example that comes to mind is data on infant deaths really contributed to the crib bumper pad bans at the federal level. We've also seen our data really direct guidelines for drowning prevention, and I didn't have time to pull up that link, but I can. And also I'll share that earlier in 2024, the American Academy of I just chatted that to the wrong person. I wanted to go to everyone. The American Academy of Pediatrics published a policy statement on child fatality review and the importance of it. So I encourage you to peruse that. I want to use our last couple minutes to share again about how folks can get involved with using these data. If you are a student or a trainee and you want to use these data, just like our researchers shared, the National Center has a team of data folks that are here and ready to work with you. We will have meetings and we will answer your questions. We will help you understand the data. A lot of that information, again, is on our data dissemination page of our website, which I will pull up again and share it. You can reach out to us at info@ncfrp.org if you are wondering about accessing the data. We can help you with that. Like I mentioned during my slides, it is through an application process, and we can work with you to help navigate it. And yeah, that's what I want to say about that. I was going to ask our presenters if they had advice to someone interested in using fatality review data for research, but they may have already answered that. And if you have any parting thoughts along those lines, please feel free to share them.
I think for us, and I think I alluded to this earlier, the National Center is an amazing resource and really willing to help out and help you understand and work through the database, especially if you're getting used to or not only secondary database analysis or specifically getting used to the NFR-CRS. So they're a great resource, and I think the collaborations and opportunities of all the investigators who have worked with the center, I think there are so many opportunities in other future directions of studies. So
Yeah, I would just emphasize if you have an idea, reach out to the National Center and just see if it would be feasible. It will help you refine your research question, and it will help you be more successful at writing up a proposal.
Thank you all so much. I don't know, I'll send it to Kristen to close this out.
Great. Thank you, everyone. Excellent presentations. It's always a great resource to bring to our members, opportunities to collaborate, to find ways to answer great questions. So I would really love to thank everyone for their participation today, specifically the National Center. You can find out more about SAVIR, about the National Center on our website. And we look forward to seeing you at future methods series. They come out quarterly, so we'll have one after the conference. And this recording and all the materials will be made available following this session. So thank you, everyone.
Thank you.
Thank you all. Take care.